Hi, everybody. It's Eric Yazel here, July 2019. Want to talk to you today about pre-hospital CPAP. Not going to get too in-depth or anything, but just want to give you some basic understanding of the mechanisms and things like that. First, let's do a couple of things for housekeeping here locally. Just reminders, make sure you have respect for your mechanism of injury. I've seen some destination decisions that probably should have ended up at a trauma center. The patient looked fine, but had a pretty strong mechanism of injury, and with further investigation ended up having significant trauma. So just a reminder to always respect your mechanism of injury. Run reviews, like I said, we're not calling report at Clark anymore, which is very nice. I think it's probably been beneficial for everybody. If you have any questions on runs or destinations, make sure to curbside us when you come by and things. We'd love to get more involved from an education standpoint. Last but not least, take care of yourself. I know everybody's short-staffed these days. There's a lot of mandatories and long shifts and things like that. So everybody make sure you're doing what you need to do for your own wellness as well. So let's talk about a little CPAP. There's our CPAP thing. Hopefully that's not you as an EMS provider that's needing your CPAP while you're on shift. That's more like it, this patient here. So, why do we do CPAP? And basically, no RSI in the field makes intubation in an awake respiratory distress patient not feasible. I mean, it's very difficult. You can do some drug facilitated intubation and things, but at least locally, very few of us have paralytics in the field and the medicines we need to do RSI out in the field, which a lot of times makes CPAP a very viable option. It can buy you some time. If you have a anticipated nightmare airway where you may need video laryngoscopy and multiple hands, all sorts of things, it can buy time until you can get to a facility where you have some help. Also has been shown to reliably reduce symptoms of respiratory distress, so it can help people, decreases the need for intubation. And I still think it's really underutilized. If you can calm somebody down and get them to try a CPAP trial, a lot of times it'll prevent them from being intubated in the first place. Some physiology, just not to get too technical on you, but there's an exchange of oxygen for carbon dioxide that occurs in the alveoli of the lungs. They have thin walls, and they're covered with what's called surfactant that keeps them from collapsing every time we breathe in and out, so they don't have to snap open each time. It's kind of a lubricant. If this is washed out, the fluid collects in the lungs, alveoli won't stay open. They'll collapse and stay collapsed. And then some actually stay collapsed at bedside or at baseline just from increased intrathoracic pressure. Here's kind of what that looks like. You've got a main bronchiole here. You've got air flowing down into the alveoli here. Some of those in the periphery will be collapsed at any one time, and the more of those you can recruit and keep open, the better the patient will do. CPAP forces a small amount of pressure into the alveoli, and it forces them to stay open. It doesn't allow them to collapse during exhalation by forcing that pressure in at a steady rate. And then the muscles that they formerly used to snap open those alveoli can now rest, and it actually significantly reduces your work of breathing. When the alveoli are collapsed, they tend to fill with fluid as well. So that continuous pressure with respiration pushes fluid out of the alveoli. CPAP also increases intrathoracic pressure. So basically that lowers your blood pressure, makes it easier for the heart to pump. So you're doing all sorts of things all at once. You're saving some respiratory muscle, and you're decreasing how much effort the heart has to do as well. This is what they call the lung function curve. And basically, to make a long story short, you're increasing down here the amount of lung that you're able to use for your respirations. So this is kind of a summary of all the things that it does. Like I said, CPAP prevents the collapse of alveoli, stabilizes the chest wall, splints open the upper airway, like in a sleep apnea kind of patient. Reduces the work of breathing. Basically, just does so many different things, as you can see, that are really important on that pathway. So when should we use it? Undifferentiated respiratory distress. How many of these people do you see that are tripod and they look awful? They sound wet. Is it pneumonia? Is it CHF? Is it just COPD? Who knows? Remember one of the last lectures we did, look at the waveforms of your entitle. That can help guide you as well. But those are the patients that are excellent candidates for CPAP. I love CPAP for DNR patients. They may not be able to keep their SATs up with just blow-by oxygen, but obviously as DNR, they don't want aggressive measures and they don't want to be intubated. A CPAP is a nice temporizing measure in their case. The sooner you start it, the better. Sometimes it takes 30 to 60 minutes at least to see effects. So the sooner you can start it in the field, the better the patient will do, and the sooner they'll start noting the effects. We talked about this. These are some of those waveforms that we talked about. Just to review again, if you're shark fin, that's your COPD. Your hypoventilation, hyperventilation, your normal waveforms up here. And those are just things that can help guide you on who might be good candidates for CPAP. Other uses, toxic inhalation. Somebody who's gotten some chlorine gas or something like that may not need intubation, but is in enough respiratory distress that a simple nasal cannula isn't working. Your near drowning, those are great ones for CPAP because that positive pressure forces some of those fluid out of the lungs. Your flail chest, where they have the paradoxical chest motion, so they require so much more accessory muscle use for their inspiration. So anything that decreases that muscle use, such as CPAP, can be very helpful. One thing that we hear a lot of lately is what's called delayed sequence intubation. I've used this several times. I'm a huge fan. And basically what you do is, you guys have all seen this, where somebody's in such respiratory distress, you're not sure what's going on. Their sats are low, and the minute you put a CPAP mask on them, they're just going to tear it right back off. Well, as ketamine is starting to gain acceptance in pre-hospital things, I think this will start to become an option for you guys as well. And it definitely is for us in the emergency room. And so what I do is I give them a nice dose of ketamine to relax them. I put the CPAP or oftentimes BiPAP on the patient, and you give them a 15 to 30 minute trial on that. What you'll find is that it's good for two reasons. Number one, if the patient is going to require intubation, you've pre-oxygenated them so well that they can tolerate 5-6 extra minutes of intubation time if they need to, if they're going to be a difficult intubation. You've really maximized their pre-intubation side of things. The other thing is, ketamine does have some smooth muscle relaxation properties and actually can facilitate the breathing, and you've calmed them down as well to where that actual CPAP or BiPAP will prevent the need for intubation in the first place. This is, the old rule of thumb was you couldn't give somebody ketamine and then put them on CPAP or BiPAP, because if they weren't responsive, if they vomited or something along those lines, it was too risky to have them on a positive pressure mask. The thing is, with somebody that's this sick and in this much respiratory distress, you're not leaving them, you're staying right by their side on the stretcher in the back of your ambulance, or, right at bedside there in the ER. So the minute you see some signs like that, you can pull the mask off. This isn't something where you give them a big dose of ketamine and then go about your business doing something else and then come back to the patient. You're pretty much locked into bedside, but with a patient that's in that much distress, that's probably the best thing anyway. So when shouldn't you use CPAP? If they're apneic, you're augmenting their inspiratory pressure. If they don't have any inspiration, you're not going to get any inspiratory pressure. So that's a time not to use it. Vomiting, we just talked about. If they're vomiting and you're given positive pressure, your risk of aspiration is extremely high. Anxiety, again, these are people that you may need to give some, Versed or other benzos to, or ketamine or some other sedation medicine, because somebody who's in true respiratory distress is likely to be very anxious, is going to have difficulty tolerating that mask, because I don't know if any of you have ever put those on, but they give you a smothering sensation. The other population, your poor clearance of secretions. So, your older people who, may be minimally responsive, anybody who basically has trouble clearing their oral secretions, CPAP's not a good option, again, from an aspiration side of things. Settings, usually use a setting of 5 to 10 for inspiratory and 5 for the expiratory phase. 5 is usually sufficient for your asthma COPD patients. 10 is often needed for your CHF, your near drowning, pulmonary edema, pneumonia patients. They usually need a little more pressure in order to clear those secretions and push that out of their lungs. Can improve work of breathing by up to 60% and increase pulmonary muscle endurance by up to 90% with those settings. So, this is a huge benefit. It's something that takes some time. That's one of the biggest mistakes I see is people get impatient. They'll watch it for 5 minutes and say, hey, this isn't working. We got to do something else. Give it some time to rest those muscles. One thing I always tell people, if a pressure of 10 is good, why wasn't 20 better, or 30? Why not keep going up? Once you get above about 20, the pressure of this positive pressure increases over the rate of pressure of the lower esophageal sphincter. So then you'll start pushing air down into their stomach and increase the gastric insufflation, risk of vomiting, and aspiration. So really a maximum of about 20 in these situations. It's a application right there. Like I said, it's easy to apply. Some difficulties are, your facial shape. If anybody's got any, old facial fractures, big, huge beards, which are obviously more popular these days, can make it difficult. But you want to try to get as good a seal as possible. The better seal, the better pressure delivery. If you've got a lot of leakage, you'll lose several millimeters of pressure off your true effective positive pressure. So what do you do? First thing I do, don't just come up to the patient and start slapping it on them. Coach them on what's going to happen and what they're going to feel. Let them know that smothering sensation is going to be normal and try to prepare them for it. Make sure they're hooked up to a large oxygen reservoir. A lot of things, CPAP requires a lot of oxygen, so you may blow through a tank pretty fast. So, make sure you're using a full tank and you've got a backup supply and things like that. When you're first applying it, one thing I always tell people to do is hold the mask to the patient's face first. Have them take some deep breaths. So don't just strap it on there and go. Hold it up to them, let them get used to that positive pressure, then strap the mask on once they've settled down a little bit. I think you'll get some better results of patients tolerating if you take that approach. Application, again, connect the circuit to an oxygen source, put the mask on, straps next, get a good airtight seal. Remember, the quieter the mask, the better the seal. And then you adjust your PEEP valve and the FiO2. So actually pretty easy, not a lot of steps in the application. That's why I say it's underutilized. It's so easy to do. So why not give a lot of these patients a trial of this if they're struggling? What can you do for it? You can give a lot of breathing treatments through it. They call them super nebs. If you fire some albuterol through with some positive pressure, you're reaching a lot more of the lungs with your albuterol and other things. High dose nitrates. A lot of people are giving nitro drips at like 200 micrograms and much higher rates than before to try to head off intubation in CHF patients. So high dose nitrates are certainly an option here. Remember, get your antiemetics on board early. You don't want vomiting with this, so you can even consider pre-treating with some Zofran or something along those lines. Reassess frequently for response to treatment and level of consciousness. A lot of these patients are going to get better. Some aren't. You want to make sure you're paying attention and you can make that transition to endotracheal intubation if it's indicated. The other thing I say is let the receiving facility know ASAP. And why is that? Obviously, the common sense thing is they're getting a sick patient. But the other thing is a lot of ERs won't have a CPAP machine or BiPAP machine readily available down the emergency room. So you need to let them know that you're bringing in a patient on CPAP and they need to get their machine down there to ease the transition and let you go on about your day. So some complications that happen, you rapidly lose up your oxygen source. Patient intolerance, we talked about it, especially your severe respiratory distress patients. They're going to have trouble with anxiety and difficulty tolerating that mask. We talked about how it decreases intrathoracic pressure, especially at your higher settings. You may see some hypotension. Even higher settings, you can cause a pneumothorax. Again, if your pressure gets above that gastric distension or gastric esophageal sphincter level, you can get some gaseous distension. If you put the mask on too tight and leave someone on it for an extended length of time, you can get some skin necrosis around where the seal is of the mask. Obviously, from a pre-hospital standpoint, doubt you're having people hooked up long enough for that. So, summary: CPAP has numerous physiologic effects that increase oxygen delivery and decrease work of breathing. Wide range of conditions it can be used, especially in your undifferentiated respiratory distress population. Application's easy, and in a compliant, alert patient, few complications. Any questions? And again, love some feedback. So any questions you have, either curbside me in the ER or right on the YouTube station here. And also feel free to suggest topics you'd like to see in the future. So thank you for listening.